I'm just loving reading the chat. It's great to see some of the things that conversations you're looking forward to today. I can't wait to get stuck into that. So as Stacey says, I'm Penny, I'm the Managing Director of Q, and I guess I have one prediction, that we'll end up talking more about the human than the technical sides of change. Now, there's plenty of great technical content in today's agenda. We've got, discussions on strategies for reducing backlogs, got an introduction to learning health systems, we're unpacking how we use data to focus on equity, for example. But overall, I've noticed that when we get into conversation, it turns more to the people aspects, co-design, leadership, collaboration. I name this because, if I'm honest, it had been troubling me a little bit. I've kind of caught myself wondering if it's sufficiently valuable to you and the health system if we spend our time only talking about the people stuff. Over the next 15 minutes, I want to share how my thinking has changed, because I guess I've come to see that it's precisely the people side of improvement that's really important for what we offer each other and the health system at a time of great need. Marjorie Godfrey says improvement in healthcare is 20% technical and 80% human. Even though our practice is underpinned by technical skills, often we invest more time on the human side or live to regret it. I cringe when I think back to when I was fresh out of university, stepping out in front of clinical teams, clinging to my process and statistical process control analysis in a bid to earn credibility. I was only through kind of failures and rebuffs that I learnt, with apologies to any of you who I worked with in those early days, that technical methods in themselves rarely get you far without relational skills. I grasped more slowly than I should probably confess that you need both human and technical skills to achieve change. And at the risk of sounding even less relationally competent than I am, I also needed a parallel journey to learn that the human side wasn't just kind of inherent, getting on with people, but had method and skill to it. We sometimes talk about the technical sides of improvement alienating people, but for me, getting into the murky realms of people and how they tick was the challenging bit. When I realised there were tools and techniques you could study and improve, that's what helped me to give it the attention it deserved. Colleagues in Scotland talk about an infinity loop between the relational and technical aspects of improvement. While we may spend 80% of our time on the human side, to achieve the outcomes we're looking for relies on both. I suggest we go one step further and think of the human and technical as two sides of the same coin. Improvement is perhaps 100% technical and 100% human. The technical methods only work if understood with a human lens, and the human skills have some technical method to them. Why is this important? Why am I talking about this somewhat theoretical point? Have the slides go back a little? Well, in bringing into focus the relational aspects of improvement and bringing a few hard lines to the contours of the soft stuff, that allows us to learn from, share and celebrate brilliant work across the community. It connects us to our shared purpose and the particular power we have to enable sustainable change, and it ensures the contribution we can make is understood at a time when person-centred collaborative improvement principles need to be at the heart of recovery. In the 7 years since Q started, we've had over 650 events run by us and members. We've published more than 500 blogs and supported over 180 projects. Looking across these riches, what amazes me, and I now recognise as a particular strength of the community, is the energy and expertise running through all of this work in different aspects of the relational or human sides of change. In your inboxes today, you'll find a blog where I've shared 10 principles for this kind of human heart of improvement. Healthcare is a people business, and the work of change is too. At an intrinsic level, this informs the work I see emerging through the community. I'm going to run through a few principles in each of these three areas quickly now, and I'm hoping that you'll give me your thoughts on these over the days ahead. So that could be via chat now, in response to the blog, or through conversations at the in-person events next week, for example. And please don't hold back with your changes and critique. It wasn't false modesty. As I admit, if working with people can ever be something that you feel like you master or have cracked, It will be by others at this event and in Kew well before it's me. So to start with the people focus of the sectors that we love and work in. When I look at the work of Kew members, I see this underpinned by belief that health and care experience and outcomes are co-produced with patients, carers and communities. A recognition that safety and quality of care relies on the skills and agency people bring to their work, and that health and care relies on people working well together. There's a wealth of material on the Kew site which brings these perhaps uncontroversial principles to life and digs deep into the insights that flow from them. So say the work of our co-production special interest group, increasing focus on equity and outcomes and experience, and many projects that seek to boost teamwork and quality of care, from human factors or Kew's lab on Kew lab work on partnership, for example. So we work in a sector that's all about people, and we also know the work of change is inherently about people, because people support changes that they see the case for and help create. We know change can be hard, and so much of the science and art of improvement is about supporting people through that. The Kew Exchange project looking at psychology and improvement comes to mind, for example, or our Kew Lab, our other insight work, which is using your experience to shine a light on the factors that will influence people to really engage in remote monitoring and video consultations, for example. There's so many examples when you dig deeper. And when we look wider, the work of identifying and adapting ideas from one place to another also relies on people to act as the translators. Kew's groups are helping create those human conduits for spread. The understanding that healthcare and improvement are people businesses runs through all the work that I see the community doing. Fundamentally, we use improvement methods as a way of going about achieving objectives that enables those affected to shape and to lead it. I kind of sense that as a driving ethos or motivation behind the work you and other members do, and indeed our drive to continually improve how we do improvement. If improvement is at least 80% human, I think we increasingly realise it's also 80% plus collaborative, and set to be even more so given our kind of ambitions for service integration. So we create kind of connections and opportunities for people to participate in change efforts with purpose, and so we can draw together all the diverse perspectives that we need. And then we build improvement and collaboration skills so that this can reach as far as possible into organisations and communities where we work. Many examples of capability building Kew members are leading. They're energised not just by some kind of technical assessment of the dosage of skills needed, but by a commitment to sharing as wide as possible the agency and control that can offer. Making sure improvement benefits from diverse perspectives is a foundation for doing better on equity too. Our commitment drives us to create contexts and cultures where people are engaged well and improvement can thrive and sustain. The work that we're doing with national leaders alongside those working at the front line, that gives us opportunity to be a positive voice for approaches to change that respect and make the most of the people who work within and use services. So where does this leave me? Well, I guess improvement as I see it, expressed through the work you do in this community, reflects a profound connection between the technical and human. Improvement is a field that's evolved over many decades now, pragmatically and ethically working with the ideas and priorities of those using and delivering services, with methods evolving and improving iteratively in response to what works in practice, bolstered by a kind of growing evidence base of which Mary will give us a taste. So at a kind of deep level, the human and technical strands of improvement have developed in an interwoven way. They're as interdependent perhaps as physiology and anatomy, circulation and skeleton. Recognising that has helped me understand the unique energy, the power we have in this community, and it's a reason to be proud of the work we do, not something to feel slightly awkward about. So the final reason why I think the human side of our work is so important, and being clear about the technical rigour that sits behind it is too, is the way that improvement is perceived, and what that means for the power that we each hold to influence the course of recovery. The skills for working well with people through change may have come easily to some of you, but they still don't to me. I can really appreciate how this difficult work is easily sidelined in the health service, especially when it's under the extreme and sustained pressure it is now. So I think we need to find a way to talk about a human-centred, collaborative approach to change that cuts through the images that may conjure for some people, images of candles and beanbags. Now, you may well be sitting at home surrounded by candles and beanbags. You may even do that because of evidence that a relaxed environment and self-care can help your resilience and your creativity. We should probably have more candles and beanbags in the NHS. But it can be difficult to lead dynamic change suited to a context of urgent pressures in public services or convince more sceptical audiences from a beanbag. It can seem out of touch with the must-do priorities facing those responsible for health and care system performance. For those who might be sceptical of what improvement can bring, I think we want to play up the kind of hard-edged benefits case for a person-centred participatory approach. So that might mean highlighting the kind of technical expertise and talking through more explicitly why this is important, even if that might feel obvious and is best kept in the background when actually doing the work that we do. We need to state clearly and consistently that change approaches that engage people effectively are the only credible way to address challenges sustainably in a complex human system. Change only really lasts when people from diverse backgrounds are involved in the diagnosis of issues and design of solutions. And only when you build the skills and understanding in those who deliver services so that they can do the ongoing iteration that's needed for even the best conceived service change to embed. An improvement done well offers ability to boost agency, morale, and teamwork in the process. As we'll explore in one of the sessions today, with the crisis and workforce a top risk to the functioning of services, let alone their recovery and transformation, the greater morale and engagement that's possible through improvement done well is very far from a side benefit. From where I sit, your ability to combine the technical skills needed to analyse and redesign processes with the change management skills to bring people with you is something we should be shouting about from the rooftops. Because it's such a strong thread through the community and it ties to the biggest challenges in the health and care sector right now, this is our recovery phase mission in Kew. I'm hoping that we can use today to further strengthen and weave together a web of ideas and energy that we can bring to this area. And after today, we'll be asking you to contribute to more structured insight gathering. So feeding back on the principles that I've shared here, as I say. And working with the institute that Mary leads, we'll be looking to develop a clearer set of metrics that we can use to understand engagement in major change on the basis that what gets measured is often what comes to matter in organisations. So I hope you're starting this event inspired by the wealth of technical human expertise and energy around you in your community, which I know will come through in every session and discussion today and at the in-person events that follow, and that you're up for continuing to learn together about the ways in which improvement approaches can power a more kind of effective, people-centred approach to change. There's a strategic case for that and a growing evidence base for what works, which the phenomenal Mary Dixon-Woods is going to give us a taste of in a minute. But first, I'll hand back to Stacey for a few minutes to reflect and share together. Thanks.